Hello, everybody. I would like to extend special welcome to Professor Alan Wein, the leading expert in voiding dysfunction, who will give the state-of-the-art lecture. Alan is a professor with tenure and Emeritus Chief Director Residency Training Program, University of Pennsylvania, Perelman School of Medicine. The lecture will be on the placebo effect, food for thought. Please, Alan, you can take it from there, and thank you for preparing this interesting lecture.
Good morning, good afternoon, or good evening, depending on where you are. It's a great honor and a pleasure to present the state-of-the-art talk on the placebo effect. These are my potential conflicts of interest. Let's go back to 2017 at the ICS meeting. One of the most heralded papers ever to be presented at the meeting was a paper on a compound called GTX-024, a synthetic androgen receptor analog to decrease stress incontinence in postmenopausal females. This was the original curve that was presented at the ICS meeting and again at the AUA meeting. And basically, this was a brief summary of the results in an open label trial. A absolutely remarkable reduction in urinary incontinence episodes, which not only resulted during the trial, but were sustained up to 7 months afterwards. The talk was entitled Kegels in a Bottle. Whoops, what happened? Well, when the study was done with a placebo and the primary outcome was the percent experiencing over a 50% reduction in urinary incontinence episodes, as you can see, the placebo performed essentially identical to the 2 doses of the compound. Interstitial cystitis. I was on this advisory board as well as the enobosarm advisory board, and I was convinced that this product had promise as well. These were the original studies on baseline pain, and various pain parameters were the outcome indicators used. This looked absolutely fantastic. Everyone had high hopes that we would be able to treat at least a segment of these patients in such a way. Whoops. Unfortunately, when subjected to a double-blind study, the results fell apart. This was the primary indicator, and the primary outcome failed, and none of the secondary outcomes were successful either. So, basically the question is, what's going on here? And I think it's a reflection of Thomas Huxley's quote. The hypothesis was great. Everything looked terrific. There was just one ugly fact, and that is it didn't outperform placebo. This is a very recent article by Chris Chappell et al. In European Urology, looking at the percent changes in placebo, mirabegron 25, mirabegron 50, solifenacin 5, and tolterodine XL4, looking at incontinence episodes, urgency episodes, and volume voided. And you can take a look at the placebo numbers, basically, and see what an incredible effect this had. Now, in the category of volume voided, you can see that the percent change was lower, certainly, but some still occurred, and that's a subject we'll talk about later, and that is objective effects versus subjective effects. This is another compilation looking at placebo results in stress incontinence, incontinence episode frequency, in urinary urgency, incontinence episode frequency, and in maximum voided volume. And as you can see, for stress incontinence and urgency incontinence episodes, the placebo results were extremely high compared to drug. And this is just a bar graph showing the results for both urge and stress urinary incontinence, placebo, and drug. Now, placebo effects are not just limited to lower urinary tract symptoms. These are results in other entities: irritable bowel syndrome, inflammatory bowel disease, ulcerative colitis, Crohn's disease, depression, erectile dysfunction, dyspepsia, basically all of these. This was in a GI journal and concentrated on irritable bowel syndrome. And some of the factors that they discussed were the fact that more specific entry criteria decreased the placebo effect, an increased number of office visits decreased the placebo effect, and there was a tendency to decrease the placebo effect with a run-in. And these were the possibilities cited for these particular effects. Now, placebo-activated effects have also been shown to affect the respiratory centers, the cardiovascular system, the immune system, hormonal responses, and an overall feeling of wellness in Parkinson's disease. In fact, Parkinson's disease is the neurological entity that seems most susceptible to placebo effects for one reason or another. Placebo effects have been cited to reduce heart rate, reduce blood pressure, as I said, affect Parkinson patients, in which they've been shown to be due to dopamine release, in terms of sleep disorders, immune responses, and the most widely publicized and best studied has been the phenomenon of pain. Now, I think a useful concept at the outset is to remember that the placebo response is different from the placebo effect. We see the placebo response in a study. That's the percentage. The placebo effect is the mechanism by which that placebo response occurs. And that's what we don't know. We know, as I'll show you, the mechanism in some phenomena, but we have absolutely no idea about the phenomena involved in the placebo effect in any of the overactive bladder or interstitial cystitis parameters. And that's what I would encourage the folks who are listening to think about and perhaps embark on some study about during the next year or two. This is an abridged history of placebos, various things that have been used. This mammary ligation was interesting. There was a treatment for angina, internal mammary ligation. A study was actually approved to compare that to just the skin incision that would be used to do that. There was a 37% improvement in angina in both groups. The modern era of placebo began with a fellow named Henry Beecher, who ultimately was an anesthesiologist at Harvard. He was in World War II in a battlefield situation, dealing with a patient preoperatively who had an extremely high risk, very high pain, and was very agitated. They had run out of morphine. A nurse got a vial of saline, told the recruit that basically she was giving him a pain medication. Beecher was impressed by the fact that this calmed the patient down immediately. He had little pain. He did not go into shock. He had a successful procedure. And on his return to Harvard, Beecher began the placebo program there. This was an article he wrote in JAMA in 1955, which is still the most cited study on placebo. He found this average in 15 studies of the placebo effect, but not only that, he found that placebos can have adverse effects called nocebo effects as well. And these were the adverse effects that were noted in these studies. He noted that there was a relative consistency of placebo effects over a wide assortment of responses that suggested some fundamental mechanism was operating. In 2005, it was found that the placebo effects on pain could certainly equal a substantial dose of morphine. Not only that, but a placebo result which resulted in pain relief triggered endorphin result or production in the brain that paralleled the decrease in pain perception. And subsequently, it was found that placebo effects on pain are accompanied by reduction in neural activities in those brain areas known to produce anxiety and pain. And not only that, the magnitude of reduction was proportional to the reduction in pain ratings. It was found that there are similar regions in the cerebral cortex and brainstem that are affected by both the placebo and a rapidly acting opioid agonist. And PET scanning has been demonstrated to show an increase of mu opioid receptor transmission in different brain regions. These are functional magnetic resonance images, natural history of pain on the left, and horizontal brain images on the right after pain relief with placebo. And you can see that there are definite objective changes which mirror the change in subjective pain. Not only that, the placebo effect for pain is antagonized by naloxone. If you give an open view of an injection of an opioid, you will get a much greater effect than if you do a hidden injection, and the effect is eliminated by naloxone. In other words, the difference between the open injection and the hidden injection. Cholecystokinin is a compound that antagonizes endogenous opioid neuropeptides, and a block of this substance potentiates opioid effects and also potentiates the placebo analgesic effect. So this is that experiment. I'm standing in front of you, giving a dose of any one of these. For pain, I'm standing behind a curtain, giving the same dose. This difference basically is the placebo effect. So placebos activate the same biochemical pathways activated by drugs for pain. Also, in Parkinson's disease, it's the dopamine receptors in the basal ganglia that are activated in these patients that experience a placebo effect. And in fact, if you look at the neurobiological correlates of placebo, there are correlates for placebo analgesia with the opioid system. There are correlates for negative expectations with the cholecystokinin system. There are correlates for exposure that's similar to pain relief by non-opioid drugs, moderated by cannabinoid receptors. As I said, in Parkinson's, the placebo effects are moderated by dopamine and mu opioid receptors in the ventral striatum. And if you look at the pain modulating network that's activated by placebo, it's opioid receptors in the prefrontal cortex, the rostral anterior cingulate cortex, the insula, and the nucleus accumbens. And this is just a diagram from this article that looks at the various areas affected: placebo, analgesia, cardiovascular and autonomic correlates, and endocrine and immune correlates. Immunosuppressives. This was an old experiment, obviously. Rats in which there was a pairing of saccharin-flavored drinking water with Cytoxan injections. In a group that were not given further Cytoxan injections, the animals kept dying at a high rate. And this was the hypothesis that even in animals, because it was originally associated with the injection, the water triggered the same immunosuppressive effects as the Cytoxan. Well, that's a very nice subjective hypothesis, but this experiment reported in 2009 seems to confirm that something objective does happen. Same experiment with cyclosporin A exposed to saccharin alone, and there are changes in T helper type 1 cytokine and calcineurin activity in CD4 T lymphocytes. Other parameters that can be conditioned: antibody responses, lymphocyte proliferation, white counts, natural killer cell activation. How long does a placebo effect last? Well, the common view is that it doesn't last a long time. That's not true in many cases. It seems to depend on the expectation of the patient and perhaps how elaborate and invasive the treatment is. This is a study on Parkinson's disease using sham surgery versus fetal tissue transplantation. Patients who believed that they received the tissue were significantly improved whether they had sham surgery or fetal tissue for up to 12 months. The effects of placebo may be rapid and may diminish with time, but look at the tamsulosin studies. The placebo effects were maintained for over a year. Look at the finasteride studies. There were no further changes in the AUA symptom score after 8 months in the placebo arm. Does placebo effect have any relation to demographics, personality, or age? No. Increased frequency of dosing seems to yield a higher response. Trials with a longer run-in have a tendency to a lower response during the actual trial. Here are two interesting experiments. Are placebo effects only subjective or can they be objective? This is in asthma patients, a double-blind crossover with these 4 arms. This is the forced expiratory volume 1, in which a 12% or over increase is considered a response. This is the bronchodilator, but none of the others had an objective response. And yet, this is the subjective improvement in symptoms. It looks as though the first 3, all but no intervention, were basically the same. Now, here's one for rheumatoid arthritis. 5 randomized clinical trials looking at objective markers and also subjective outcome measures. They both improved to a clinically meaningful effect. Why is this? Well, here basically are the diagrams. This is the pain scale. This is the C-reactive protein, and this is the sedimentation rate. So both subjective and objective results. Can you tell who's going to respond to a placebo? Well, perhaps. This is just one study looking at responders to irritable bowel syndrome. And as you can see, there is a particular genotype that seems to respond preferentially using change in this IBS symptom score as a primary outcome indicator. Finally, can we transmit beliefs to our patients even though we think we're not? Well, we can. This is a fascinating article that just came out in December, where they used college students with role-playing, doctor and patient, and a pain relief placebo that they entitled Thermidol. And they convinced one group by simply decreasing a pain stimulus and using Thermidor that this was the real item, and another group that dealt with supposedly placebo, that there was no effect. And what they found was that the provider's expectations, and they did this in a reverse model as well, about the efficacy of a treatment could substantially affect the group that pretended to be patients, their outcomes, by what they called implicit social cues. So their conclusion was that, yep, we do send nonverbal information that communicates our belief as whether a treatment is liable to be effective or not. Here are some factoids. More expensive, more effective. Device greater than pills. Surgery greater than injection, greater than big pills, greater than little pills. So the possible contributions to the placebo effect, no doubt, all of these are true. And this was known as early as 1994. These basically haven't changed. Natural history, regression to the mean, specific effects of unintended active components, provider attention, et cetera, et cetera. However, I think it's important to remember that the actual placebo effect can include and does include, has to include, some neurobiological as well as psychological mechanisms. It differs from the untreated natural history condition. Can we use any of these effects? Well, this is kind of an interesting article looking at non-malignant pain, and what they found was apt to increase the placebo effect. And if you look at these, they're things that we probably use, some of us, in our office care, whether we're conscious of it or not. Prescribing an intervention that was previously used and failed is what I call the KOD, the kiss of death. Tell the patient the intervention is liable to be effective. Self-care, etc. Don't spend a lot of time on the major side effects. Spend some time basically on the side effects that may be associated with positive outcomes, like dry mouth or something like that. And in the office, employ a friendly office staff. You can use sham physical treatments. You can increase the frequency and duration of visits. Don't rush a visits, etc. So all of these, you can actually use, these folks found, in at least positively affecting the placebo effect for non-malignant pain. So in summary, let's review. True or false? Not completely, that's for sure. Ample evidence? Well, there's also ample evidence that the placebo effect lasts a long time. False. Affected by yes, 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 no. A placebo can affect only subjective parameters. False. Yes, yes. The jury's still out on this one. I think it affects a binary response more than a continuous response. Can cause objective changes. Yes. Placebo reactors are different. Maybe in some cases. We are placebos in our own right. Absolutely. There are placebo effects that occur in animals. Definitely. And finally, can we use these in clinical practice? Yes. Should they be used in clinical practice? I think so. So what's the way forward? Well, we need to find out what's responsible for the placebo effect in lower urinary tract symptoms. Is there a biological correlate to any of all of them, or any or all of these? If so, that could be useful in determining the pathophysiology and also in promoting perhaps a different form of treatment. Is it as simple as behavioral modification, as Sender Horshorn has published with respect to fluid intake and frequency? Well, I don't think so. Who tells these patients to drink less fluid? And in the case of stress incontinence, who tells them to do whatever they do to decrease the number of incontinence episodes and in urgency incontinence episodes? And finally, should we care if a clinical trial shows a positive result of 70%, even if the placebo response is 50%? I don't think so. What is the patient experience? The point is, if they're better, they're better. Should we consciously try and enhance the placebo effect in our patient management? Well, I think so. And thank you.
Thank you, Alan, for this inspiring lecture, and really it's food for thought. Now it's open for questions. I think, David, you have a question for Alan?
Yes, yes. The jury's still out on this one. I think it affects a binary response more than a continuous response. Can cause objective changes. Yes. Placebo reactors are due in some cases. Those in our own right. Absolutely. There are placebo effects that occur in animals.
It's muted.
Definitely.
Okay, sorry. Can you hear me now? Okay, Alan, I would like to, thank you very much for that, such a beautiful presentation. I have a question. So how big is the placebo effect in patients with ORB after first and second line therapy? How do we know which is due to the effect, placebo effect, and which is due to the therapy?
You're talking about after first and second line therapy, right?
Yeah.
No, I think that it's most likely less than it is with first line therapy and second line therapy. However, there are some studies that show that the more invasive the procedure, the greater the placebo effect. And I'm quite sure that even in something like neuromodulation, where we all would agree that, yes, there really is an effect, although I don't think anybody's quite sure what the mechanism of the effect is, there's still a very large placebo effect that does occur. And, the purpose of my giving the talk as it was given was twofold. Hopefully, people will be encouraged to look into what the mechanism of the placebo effects that we see really are. And secondly, I think we should use more of the placebo effect in our routine daily care of patients, because I think it really does help, whether we like to believe that it does or not. In other words, it's not all the medications and the treatment, it's a little bit of the social affect that we transmit to the patients, either consciously or unconsciously, that makes them feel better.
Yeah. Okay.
I have a question for you, Alan. When we do studies on new medication, what's the difference between when we counsel the patient, take their consent? Sometimes we leave it open about side effects. So it's self-reporting. If you have any problem, let me know. And most of the time, we go through all the side or adverse events. And in my own, any comment?
Well, I mean, placebos do have negative effects. You know, Henry Beecher showed that even as far back as 1955. You know, they're called nocebo effects. And I think that if you describe what the potential side effects are of a medication, then you can see in all the overactive bladder trials that a fair number of placebo patients have things like dry mouth, they have things like constipation, they have things like headaches, etc. So they're, and depending on how much you emphasize those, I think that the more nocebo effects they're going to have. Now, one thing that's for sure, if you can associate a nocebo effect with getting better, then I think the placebo is much more apt to be successful. In other words, if you tell someone, look, you may get a dry mouth, but if you do get a dry mouth, then that's actually good from the standpoint of what we're trying to do for the lower urinary tract. Or, you know, if you're managing an interstitial cystitis patient and you're doing eradication of a Hunter's ulcer, however you like to do it, if you tell them, listen, you're going to get worse for the next few days, but then you're going to get better. Well, they will get worse for the next few days. And I think those people are much more apt to get better than if you say nothing.
Thank you.
Thank you, Alan. Any other questions? I thank you, Alan, for very inspiring lecture, really deep thoughts about it and many tips to take to our practice and how to deal with our patients, maybe including more counseling or physician extenders that can have more time to spend